Introduce yourself in the chat box. And now I just want to go over a few housekeeping items before we get started. Next slide, please. So participant microphones have been muted at entry. If you have questions during the event, please use the chat box. This session is being recorded and will be emailed out to all participants once it becomes available. If you have questions after this session, please email newengland@mhttcnetwork.org. At the end of this month, we will send you a certificate of completion for any MHTTC webinars that you can then submit to your particular board for continuing education credit. Please contact ifisher@c4innovates.com for more information after the event. Next slide, please. This slide summarizes some of our MHTTC acknowledgements. Next slide. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear and understandable, and lastly, consistent with our actions, policies, and products. And with that, I will hand it over to Dr. Michelle Friedman-Yakubian for some introductions.
Thank you very much, Lola. So it is my absolute pleasure to introduce Dr. Julie McCarthy, who is a clinician-scientist in the Division of Psychotic Disorders at McLean Hospital in Belmont, Massachusetts. Her research aims to identify neurobiological and psychosocial treatment targets and develop and evaluate treatments for individuals and families who are experiencing co-occurring psychotic and substance use disorders. She is particularly interested in using telehealth and a multimodal approach to better understand and address barriers to treatment, with the goal of enhancing motivation for recovery-oriented behavior change through personalized medicine. Dr. McCarthy's work has been supported by the National Institutes of Health and awards from the College on Problems of Drug Dependence and the Society for a Science of Clinical Psychology. Dr. McCarthy is a clinical psychologist specializing in evidence-based treatments like cognitive behavioral therapy for individuals with schizophrenia, depression, anxiety, and community reinforcement and family training, or CRAFT, for families who are interested in helping someone with addiction. So welcome, Dr. McCarthy.
Great, thank you so much. So I am very pleased to be here with all of you today. And first up, we will be going a bit over, why families are important to incorporate in psychosis-informed care. And then we'll talk a little bit and hear a little bit about how to think about how you can best talk with the families who come into your clinics with an interview with a family member who's been on the other side of the clinician table. And then we'll go through an example family meeting with Dr. Friedman-Yakubian and myself doing a bit of a role play on how maybe not to do things and how to do things a bit better as well. And then we'll end with some resources and Q&A. So if you have any questions, feel free to put them in the chat as we go. All right, so why are we even having this topic? Well, first of all, 95% of people with early psychosis have family member involved in their care typically. So that's the majority of people in one way or another. And why might this be the case? Because the majority of people tend to be living with some family member in their life. So that means that they have a lot of great contact with family, and families might have the opportunity to notice what's going on in the early stages of the course of psychosis and throughout, should there be a recurrence of symptoms too. And families can be particularly key, if they have a relative who's in a difficult spot with psychosis or their recovery in general, in terms of connecting with care, the logistics of scheduling appointments, researching different opportunities and helping to support, financially or otherwise, people really taking advantage of the resources available to them. And what matters about this involvement, not only to us as clinicians, but the clients themselves? Well, when we have family interventions for people who are experiencing things like schizophrenia and other forms of psychosis, it's associated with reduced relapse. So no one wants to go back to the hospital. And I think this is one of the big motivations for including families in psychosis care. And people have also shown that when you go from having no family meeting, for instance, in 1 month, to even just adding at least one family meeting, that's associated with greater social functioning in those clients with psychosis. And so by including the family, we not only get the benefit of additional support for the clients themselves, we can also build our understanding of what's going well with our clients, and also potential areas of concern too. And what we also know is that the quality of the family support makes a difference. So having more warmth and positive affect is linked to having a lower risk for subsequent psychosis relapse or rehospitalization. And 94% of folks actually elect to have their families involved in care. 59% have unrestricted access, and a smaller number, about 35%, still want their families involved, but maybe with certain conditions in place. And so ultimately, I think this really speaks to the fact that clients with psychosis really do, on average, appreciate having supportive and understanding families in their corners. That being said, there are, of course, challenges too. So one of the challenges is around confidentiality. So a lot of folks who are experiencing psychosis might develop this in their late teens and early adulthood. Throughout that period, most of our clients are adults, and so they have the choice about whether or not they would like their family members involved. And so what this can do sometimes, if that line of communication is not open, is to lead to a lack of information. And in the absence of knowing what's going on, sometimes family members can get quite worried about knowing whether things are going well or not so well. And they're led to, by no fault of their own, make certain assumptions because they just don't have any other information available to them sometimes. Another challenge is stigma, where folks might have different views on seeking treatment, or what that means to have a diagnosis of psychosis or any of the co-occurring concerns that our clients might be experiencing. And then fear in and of itself can be a challenge for clients. So for instance, some people say that they're wanting to actually have maybe less involvement or less communication with the family because they want to protect them. They're not sure that their family would be ready to learn about the things that they're experiencing. And so they choose not to talk about it. And last but not least, from a clinician perspective, we all have a million things on our plate. And so time and resources can be a barrier for ourselves too. When you're already trying to manage all of the appointments that you have with the folks who have lived experience with psychosis, sometimes it can feel quite daunting to think about additional meetings or communications with family members as well. That being said, when we think about psychosis-informed care, that is a family intervention in ideal circumstances. All right, so now we'll talk a little bit about how to talk with families experiencing psychosis. So first is, how do you get this conversation started? It may not come up naturally from the client. It could, but if not, we definitely would recommend introducing this idea upfront with a brief rationale on why it could be a decent idea to consider. And in this conversation, it's so important to empower clients to think about how they would like their family involved. Realize that what your idea of involvement could be different from theirs. And so we want to meet folks where they're at. And in this discussion, you can go over the potential benefits, the reservations and pros and cons discussion. And as you do so, it can be useful to listen for cultural considerations. Are there any expectations about the role of family decision-making in care? Or are there concerns about someone's background that might involve trauma or an unhealthy relationship with a family member? That would be important to know about too. And either way, providing options helps people be active participants in the shared decision-making process to let you know what they feel comfortable with. And sometimes they won't know unless they know what's available too. And so this could take the form of family joining one of their sessions together with the clinician and the client, or for you as a clinician to meet separately with the family member. There can also be multiple levels of confidentiality. So there could be free, open communication, or it could just be permission to communicate about certain things, or certainly to always receive information that is always allowed. And then after that, you can request a release of information, knowing that they can always change their mind. So hopefully this takes the pressure off of any clients. And then ideally scheduling this family contact on a regular basis or as needed can be helpful to keep those lines of communication open. And so one example of how you could broach this topic with a client could be something like, hey, could I share an idea? Kind of ask permission first. It could be helpful for us or useful for us to speak with your family together so they understand a little bit better where you're coming from or what you're going through, and for you to share what support would be most helpful for you. What are your thoughts? So you can kind of keep the door open without feeling like you're being too prescriptive. And so we're going to hear in just a moment a bit more about what the experience has been like for a family member, a mother in particular, of an adult son who's had a history of psychosis and substance use, and how her interactions with the clinical teams have evolved over time. One of the first questions that I had for you was, what has been one of the most positive experiences you've had working with mental health clinicians as a family member?
The most positive experiences I've had are when the clinicians are compassionate, and they're willing to share some information, because as a family member, and I'm a mom, it's very stressful when, especially if there's an emergency. If it's a regular routine visit, it's fine. But if there's an emergency, compassion, some empathy is so critically important.
Yeah.
And just, if I can get any information, I understand the age barrier, but sharing something, because obviously if there's an emergency, I'm very worried. On a routine visit, I get that it would be private and confidential.
What matters most to you in terms of the type of information that you would find helpful?
What matters most is knowing the truth. I did have some background knowledge, but yet I missed the warning signs. And so when a clinician can share with me how my son is doing, am I on the right road, in some honesty, like if we're doing something that we shouldn't be doing, or responding in a way, anything that would help us. When someone's severely mentally ill, it's so important to work as a team together, because we're all in it together. We want the best outcome. I know the clinicians want the best outcome. I know my son wants the best outcome.
Definitely. Okay, so kind of coordinating with multiple members of the team and the family can be helpful. Great. Say you're working with a new provider or maybe a new team. How can providers make family members feel welcome and comfortable when meeting for the first time and talking about psychosis, which some people may be more or less familiar with?
Providing information, especially when someone's newly diagnosed with psychosis, it can be scary. It can be very stressful. As a family member, it's a whole new world. It's not the same person sometimes that you knew. Like, my son's very gentle and kind, and then there's days that it can be scary.
Got it. Okay. Thank you for sharing. And that's not easy all the time. And what would make you feel personally heard and understood in one of those interactions?
Listening to what I'm saying. I had an experience where my son was extremely psychotic, and he was also using substances, and very psychotic. And when I was speaking to the psychiatrist, he was on a 20 milligram dose of Adderall. It would get increased by 10 more. And I was so confused. And then the next appointment, 10 more. So we were at 40 milligrams of Adderall, and I knew I wasn't being heard. And so I started putting things in a text, a very, this is the mood, this is the behavior, this is the sleep pattern, just hoping to, and that did help. And I do think that I was being heard, because I think in the beginning I didn't really have a voice. Like, I knew I knew a lot about my son, but I also, the clinicians know a lot too. And so I kind of didn't understand the value of my input, and I was a little more intimidated by clinicians. And so with the help of my therapist, I have learned to advocate a little more clearly for my son.
Okay, wonderful to hear that. Any other examples of a time when you wish an interaction had gone differently with a clinician?
Another one was with one of his therapists. At the time, he was drinking heavily and going to a bar very frequently. And so I went in for a family meeting that the therapist called. And, he told me all about how my son needs his people, and everybody needs their tribe. And this was his tribe. And, and also, then when the drinking got too much, he started recommending marijuana use to help reduce anxiety. And so, yes, and clearly we moved on to a different therapist at that point, because I feel like any background in psychosis is not going to be advocating for marijuana
Right.
use as a
Okay.
reduction in anxiety.
Right. So ideally having kind of helpful but also up-to-date information on the role of substances where cannabis can increase the risk of psychosis or rehospitalization, and having consistent messaging around that from the family member and the therapist sounds
Yes.
like what you'd want. Okay. How regular would you say family meetings are for you these days?
Family meeting, like with well, sometimes we have them with the psychiatrist.
Mhm.
If my son's not doing well, he will ask for me to come in, and that is helpful because he's
Mm.
getting another side of the, you know what I mean? Like not a side of the story, but he is,
Another perspective.
yeah, he's getting another perspective. Yes.
Mhm.
Yes.
Okay. So I love how you're also saying that your son has insight as well about when it makes sense to recruit family members into the
Mhm.
conversation too. What do you feel like have been some of the challenges that you've encountered aside from maybe some misunderstandings, or being on different pages with folks, when you've communicated with his providers? Like, has it ever been tough, getting in touch with them or things like that?
Um, no,
Okay.
I would say I've been very lucky to be able to, I mean, some of the people at the psychiatrist's office are amazing. They are thoughtful and kind and humorous, and they know when to bring all those things out.
Sure.
And as far as a therapist, like if I need to, except for that one therapist, I rarely will text, but if there's something that's happening in my son's life that's critically important, I
Mhm.
will let a therapist know, not asking for feedback, but or a response, but just to like, hey, this happened like when he was hospitalized, like something like that.
Right. So you always know that you can give them information even if they may not give information
Yes,
back to you.
yes.
Okay. And how did you learn that? Did you know that from the beginning, or did you kind of figure that out over
Because
time?
I happen to have, and I was told from the very first day he was diagnosed to get myself a therapist, and I didn't for 2 years. And then when I did, she informed me that that was okay to do.
Okay. Well, hey, glad you have the support.
Yeah.
Um, and so what information or resources do you wish a clinician had shared with you sooner?
So many. So when he left the hospital the first time, we knew
Mhm.
nothing. It
Mm,
was mind-boggling. It was devastating because I just had the memories of my mother, and I'm like, what does this? I have no idea.
right.
And so we left to a local mental health center, and it really wasn't that great. And we didn't know anything.
Mm-hmm.
And so piece by piece, I'd meet someone who knew something. Or so what I wish I'd learned about NAMI.
Mm-hmm.
I wish I've heard of them before, but I hadn't known. Like, I think the family to family classes are critically important,
Yeah.
especially a good one. Like, I had great leaders, so maybe they're all, assuming they're all great. Um, any support groups, any
Mm.
research opportunities.
Mm-hmm.
Just, that's how we learn. Books, anything, any
Mm-hmm.
pamphlets, anything that you can give us, because it's a very isolated world. It's not a lot of like I'd say about 30% of the people we've told we've met with deep stigma from,
Oh,
and
okay.
another 30%, it's polite, but it's a little standoffish, and then 30% are very supportive.
Mm-hmm.
So the more information that we can get upon diagnosis, the better.
Okay. And I'm glad that there have been some supportive folks, and also I'm sorry to hear that you have been met with some stigma.
Mhm.
Do you mind if I ask, what that's looked like when you've encountered it?
And in one place that I encountered stigma was a hospital.
Mm,
It was a local hospital that he was sent to, and I went to visit, and I was absolutely appalled. It was them standing behind the plexiglass. He was the only patient on the unit, and he's a very passive guy. He's a very passive guy,
mm-hmm.
very confused, but they would stand behind and mock him. And then eventually they brought another girl in, and they in front of me, like I was watching this,
Hmm.
and it was just heartbreaking to watch. I'm
Yes.
like, this is your profession. You should
Right.
be understanding that these people are in crisis.
Mm-hmm. And it's not a joke. And
No.
I think it kind of speaks to not only how we want our clinical staff, to work with our family members in respectful ways, and us as family members ourselves, perhaps, but also to do so even when no one's watching.
Yes.
Yeah.
Yes.
Okay. What would you want clinicians to know about the experience of being a family member of someone who's lived with psychosis?
I'm going to say I'd want clinicians to know that, especially in the beginning, it's lonely, it's confusing.
Mm-hmm.
You don't know what you don't know. It's hard. And I see this when I'm in mom groups. I see, like, because we're in year 6, and I see the moms in year 1 and 2, and they spend a lot of time crying in the support groups. They're devastated. They haven't reached out. Like, when you're like, well, if you support, in the beginning, there's not a lot of support. And so
Mm-hmm.
to just support these families, to understand that they don't know what's going on, and we're dealing with a lot. Like, there's a lot of lack of sleep, a lot lack of support. And as the years go on, obviously for me now, it's year 6, and so I've gotten a lot of support now.
Mm-hmm.
But in the beginning years, and the stigma is still real, especially for severe mental illness.
And what has been the most rewarding part of your journey so far, navigating recovery with your son?
So the most rewarding thing is that I have learned the real value in being present, so I don't miss the good days. So
Mm-hmm.
when there's good days and even good moments, I embrace them. And I once told someone that, someone was doing something that was good, and he said, "Oh, I'm not riding that roller coaster with you." And I said to myself, well, I have been on my darkest days, and learned what it means to be taken to your knees in fear and just terror, like, for your loved one, for their safety. And so when those good days are here, I am going to embrace those days.
Yeah.
And my relationship with my son, I have a lot more knowledge about him. Um, and I think we have a pretty deep relationship. Not that he always appreciates that, but as a mother, like, there are days that and I've also met some wonderful people along the way. I've learned a lot about mental health. I've learned a lot about the brain. So yeah.
Okay. Thank you so much for sharing. It's been a pleasure speaking with you today. And, I wish you and your family all the best going forward.
Thank you so much. And keep up the good work.
Thank you. Okay. One of the first. So let's move on to our interview highlights. So here you had a chance to hear me interview this mother, and I think some of the highlights that I took away from the conversation were certainly making sure that we're always wearing our compassion and empathy hats when we're working with families, and really thinking about how we can practice the team-based work that we do to not just think about clinicians as part of the team, but really the clients themselves, being the leader of the team, clinicians, and their family members as well. And really try to think about how we can personally value family perspectives and also communicate that to families too, so they feel like they can speak up and contribute what they can to the conversation and the treatment plan as well. And thinking about how we can communicate updates and resources, while of course respecting confidentiality is a balance. And also, as you had heard, having some information rather than not enough won't necessarily be too overwhelming. It's something that families can digest later, but just even knowing that there's something to reference can go a long way. And then, of course, being honest. People want to know the truth. We don't need to necessarily sugarcoat things too much, as long as we're direct and respectful when talking with them. And we can ideally practice being respectful, even when we're just talking amongst colleagues, because those attitudes and approaches certainly color all of our interactions, with our clients, with our family members as well. All right, so we also want to keep in mind that the family members and clients are the experts in their own experience. We bring our clinical knowledge, they bring their lived experience knowledge, and we can stay curious and non-judgmental as we work with them. And one way to do that is by using open-ended questions, which you'll see a bit in a moment, and try to use the client and family's preferred language, whether that's be how they talk about symptoms of psychosis or the substances that they might use or not. And just remember that every family is different. So now we are going to get started with a little example family meeting with Michelle and I doing a role play. And so a bit of background for this will be the client in one of the clinics is Jamie, 18 years old, who gave their clinician who will be me, Julie, permission to meet with their mother, who will be played by Michelle, and we have permission to meet alone to discuss psychosis, kind of psychoeducation, and Jamie's treatment. And so Michelle and I will have just finished discussing Jamie's diagnosis of schizophrenia. Okay, here we go. Oops. So let me stop sharing my screen so we can do this role play. Okay. So
I was trying to figure out how to pin our videos in case
oh,
it's confusing to
there we
find
go.
us.
Perfect.
Awesome.
Thank you.
Thank
Okay.
you.
And action. So Michelle, I've just talked a lot about, Jamie's diagnosis with schizophrenia. Do you have any questions?
Yes, I do. So Dr. McCarthy, Jamie, I don't know if you know this, but Jamie was using a lot of pot right before going into the hospital and getting psychotic symptoms. And I think that the pot was really responsible for their symptoms. And I'm wondering, is the team going to tell them to stop using pot? Because obviously it's really bad for them. And I don't know why they're continuing to use.
Right. Honestly, they probably already covered this on the inpatient unit with Jamie. So I'm pretty sure they're already aware. So if you just stay positive, things will probably get better. Not everyone who's using pot continues to use pot.
Wait, I'm confused. What do you mean stay positive? Positive about what? I mean, I'm like, Jamie was just in the hospital, and I don't know what's going on, and they're still doing all the behaviors they did before the hospital. This is really concerning. Aren't you worried about this?
Fair enough. We do see this a lot, and we take a harm reduction approach. Moving in the right direction, they'll probably make the change eventually. And so, maybe one thing you could do is start thinking about, just making sure Jamie doesn't have any access to any money to buy pot, and kind of keeping an eye on that.
Wait, I'm sorry. You just said so many things. So you said a harm reduction. I don't know. I mean, it's real. Do you know that it's really harmful? Like I've been reading online about pot and psychosis, and it's really concerning. But when I tell Jamie about what I read, they're not interested. And I kind of feel like you don't even know what to do
I'll just
for
pause you here for
Jamie.
a moment. So, I do have a lot of experience with substance use and
Do
psychosis,
you?
and we'll figure
Okay.
it out.
Wait,
And
no, but
scene. Okay, so our question to the audience, and thank you so much, Michelle, is what could have been better? Feel free to put your thoughts in the chat. Because I will be the first to admit this is not exactly how I would run a typical family meeting. Okay, yes, so we've got some not validating the mom's concerns, using too much jargon, maybe just kind of starting from the basics, too much information all at once, maybe having some better active listening would be good, maybe platitudes, minimizing, not a great thing. Right, validation again, very dismissive. The what is harm reduction question, yeah, be more authentic instead of kind of just going through the motions a little bit, and really slowing down the process too. Listening, as the interview had mentioned as well. And thinking about, right, not necessarily cutting Michelle off and having too much toxic positivity. Yeah, I mean, we definitely want to instill hope in families. And also, these are some of the most difficult times that families might be going through. And so, right, eventually improve kind of the uncertainty that comes with that comment that can be really difficult to hear as well. So there are a lot of great comments here. So definitely thank you so much for including these in the chat. And I think we're really highlighting that there's difficulty with active listening. There's definitely this dismissiveness and power dynamic that's coming across pretty strongly. And right, we could have had a peer support specialist here to share their lived experience as well. I love that idea. And really kind of come at this from a more collaborative place. So I am going to just highlight the don'ts. We don't want to rush, throw in jargon without some sort of explanation, just go off of the clinician's agenda, certainly not dismiss or minimize the family experience or be overly directive with just assuming what needs to be done in our mind is the only thing that's of concern to the family. All right, so we are going to break and do this over again and try to demonstrate a little bit more about some of the suggestions that you had in the chat. Okay, ready and action. So Michelle, we've been talking a lot about Jamie and what this whole diagnosis of schizophrenia means. What, if anything, else is on your mind right now?
Thanks for asking. I am really, really worried about Jamie continuing to use pot. I think you probably know this, but they were using a lot of pot before they developed symptoms and went into the hospital, and they're continuing to use,
Mhm.
and I'm really concerned about it. Wondering if you guys can make sure you tell them how bad it is for them so that they stop using.
It's completely understandable that you are concerned. And I'm glad that we're on the same page, that there is this risk between using pot and having psychosis. So I think we're all on the same page. No one wants Jamie to go back to the hospital, and Jamie certainly doesn't want to either. So yes, I think that having some conversations with Jamie probably might make sense. Do you mind if I ask what you think might be helpful so far in terms of talking to Jamie, because you know them best, you know after themselves?
Yeah. I don't know. I mean, I've tried things like, sharing stuff I find on the internet about
Mhm.
the relationship between pot and psychotic symptoms, and I've sent
Mhm.
it to them, and they're kind of like, well, it helps me. I feel better on it, and
Mm.
it's how I connect with my friends. And
Mhm.
I just don't know. I mean, I really don't know what would be helpful, but I sometimes I do worry whether the team is really telling them about these concerns. And I kind of wish that maybe if the team told Jamie how bad it is, that they would listen more to the experts than to me.
Sure. And thank you. It sounds like you've been doing so much to try to share what you know about pot with Jamie. And also that Jamie might not feel like they're in a place right now to make changes around their pot use at the moment. And so, yes, is it okay if I share some ideas?
Yeah, that'd be great. I am desperate for ideas. Thank you.
Okay. So, sometimes when people see pot as an issue, in an ideal world, it would make sense to think, let's just cut that out and then we won't have to worry about it. And also, when folks aren't ready to make that change themselves, sometimes thinking about how we can understand a little bit more about the function of pot, in Jamie's life. That's one strategy that can help. And then also explore with them, what they do get out of it. Because clearly, if they're continuing to use this, even though you've seen that it's caused some concerns, um, there must be some reason. So understanding where Jamie's coming from is an important step. Another part of this is also exploring with them to what extent it may be making it more challenging or difficult to reach their goals. Very few people come into the office and say they want to cut down substance use as their primary treatment goal.
Mm.
Instead, a lot of folks say, they want to work on getting through school, getting a house, maybe getting into a relationship, getting a car, whatever it might be, and they want to help people get there. And so those are some of the reasons that can actually help people feel motivated to make changes with their substance use too. So maybe we can explore together, potentially in a family meeting with Jamie, or when I talk to them next, about what their thoughts are on this. What do you think?
That makes sense. I just really wish they would stop. I mean, I worry that even them using any pot is going to cause them to go back into the hospital. And that was so hard on everybody
Of
when that
course.
happened.
And end scene. Okay, thank you so much. All right, so let's return to our PowerPoint slide for a moment and just briefly share in the chat, what do you feel like went well this time? Hopefully I improved a bit from the first role play. So more validation, much more collaborative, trying to be curious, offering strength-based solutions, prioritizing Jamie's goals, right? Um, really trying to think about actionable steps versus just throwing out some jargon and trying to be more empathic. Yeah. And asking more information and insight from Michelle, because she's bringing a lot to the table too. It's not just about me giving information as a clinician, right? Having a conversation where the family can feel empowered to think about how they can be part of these conversations. Yep. And acknowledging the struggle and asking permission as well to share my ideas. Sometimes we can model these things as clinicians that we also hope that our family members will model with their relatives as well. And yes, allowing Michelle to share freely, kind of slowing down to give her the space to talk, I think it was important as well. So thanks everyone for your thoughts. And so what I was trying to do is take the time to listen, explain any technical terms and what I actually meant, prioritize what's most important to the client and their family, validation, and asking permission before just offering my advice or solutions. And so as a best practice tip, even though this is kind of a one moment in time role play, ideally we would have regular communication with the family whenever possible, without feeling like we need to share everything under the sun with the family either. Okay, so now we will just briefly touch on resources and then we'll move to our Q&A. So some of the resources that we can share with families, may or may not be new to us as clinicians. And so there's always new things coming down the pipeline. So some different supports and services are listed here in terms of reminding folks that they can get their own individual treatment themselves. Dr. Friedman, you had mentioned that I do some research as well. And one of the things that we learned is that for family members who do have loved ones with early psychosis and substance use, the majority of them, actually 75%, had reported having their own mental health concerns in their lifetime. And so I think that getting help for oneself formally in the form of support groups can be really helpful. And then certainly keeping in mind NAMI resources and additional resources local to Massachusetts are really helpful as well. Specifically, MACnet always has a growing list of resources to keep in mind. And we can also think of kind of asynchronous resources for family members too. Kind of thinking about online videos that could be helpful for families to watch, books like You Are Not Alone, the NAMI Guide, School of Hard Talks by Dr. Emily Klein, who's in our Boston area, and also I Am Not Sick, I Don't Need Help, kind of the LEAP approach by Dr. Xavier Amador. And we also have free online resources as well here. I lead the Crafting Support Project family webinars, and you can think about, what you want to offer to families, as much or as little as might make sense, but just even having a running list for yourself for what you can offer to families or how you can stay up to date on your own knowledge could include resources here, in addition to webinars like this. If you're looking for something that's a little bit more explicit, kind of manualized for how you can have some of those family conversations, because we didn't get into all the content that you could cover with family members. The Navigate Family Education Program, the latest version, is really helpful. It's freely available online. And what it would look like if you were to go to the website is this. You'd be looking for the Family Education Manual. I'd recommend the most updated one. And there it kind of breaks down very well what you can do in terms of how you talk to families, and then module kind of step-by-step resources and handouts that you can walk through with families or they can look at on their own. All right, and so with that, that brings us to our Q&A. Thank you very much.
Thank you so much, Dr. McCarthy. That was a wonderful presentation. And also, I just want to send a special shout out to the family member that you interviewed, who I think shared so much rich information. I think we have about, we can probably do at least 5 minutes of questions today, maybe 7, if folks are able to go a little bit past 1:45. Maybe we'll go to 1:50, give people a chance to have, to get to their next thing. So there are a couple of questions related to poor insight. So there's a question: if a client is in denial of their diagnosis, do you think it's best to do an initial session, maybe psychosis education with the family without the client, rather than all together?
That's a great question. I think that there are options. I've definitely been in, those initial meetings where everyone who is involved in the family, parent, the client, they're all there together. Or sometimes most of the meetings are with the family and the client together. That being said, I don't think that's necessarily the most common way to go for all the sessions. And so giving people a choice, I think, can help. And to the extent that someone does not have a ton of insight about what might be going on with them, maybe they have anosognosia, this idea that they might not really see their psychosis as psychosis at all, or might not understand why their families think they need help. If they're allowing it, it would be great, sure, to have a conversation perhaps together with the family and the client there as well, and perhaps each separately. And this isn't too far off from what folks do for actually younger clients as well. So as much information as possible in whatever way you can get it, I think would be helpful, as long as you're respecting the wishes of the clients and the family.
Thank you. And Melissa asked a question right after the video that said, how does this change if the family is not as involved and understanding as the mom in the video, or if the client is more suspicious of the family's intentions?
Yeah, I think those are great points to bring up. So if a family is not as involved, and sometimes that happens for various reasons, whether they are not believing that there is a need for help, or maybe they live abroad or something like that. Really thinking about, from the client's perspective, why would they like their family involved? Trying to get at kind of their motivations for what could be helpful in their mind. Certainly as clinicians, we just talked about all the reasons why this could be helpful to loop the family in. And so maybe understanding from the client's perspectives what they would like in an ideal world, what they see as the barriers, could help you as a clinician figure out what might even be possible. And what I mean by what might be possible is, how much you might be able to even contact and share information with a family member, even if they're not willing to join a session, or talk with a client about how they could share information that they want the family member to know themselves.
So when you want to try.
If someone could mute themselves, that would be perfect. Thank you. So those would be a couple of options. So either thinking about talking with the client about their needs, how they could advocate for more communication and direct support from the family member, having the clinician reach out, or in the absence of the family, thinking about how else they might be able to get the support that they're looking for, whether that be from found family, friends, peer supports, other members of the clinical team, or more.
Amazing. Thank you. One more question from Deborah asking, are there any recent studies linking use of cannabis to developing schizophrenia?
Oh, great question. So yes, there have been a series of studies over time, probably over the past 10-ish years or so, linking the use of heavy cannabis. Often this is more of a higher risk during adolescence, but certainly not exclusive to that necessarily, in increasing the risk for psychosis, including things like schizophrenia, schizoaffective disorder, and other forms of psychosis. So it's not as though cannabis is only something that could cause psychosis in the moment, or cannabis-induced psychosis, which is a jargony term to say that you're experiencing some of those symptoms of psychosis, like maybe hearing voices, having certain beliefs that other people don't have, when you're intoxicated or during the withdrawal period. So even outside of those periods of use or immediate withdrawal, yes, cannabis can increase the risk of subsequent psychosis.
We've got a few more questions. I don't know if we're going to be able to get to all of these. There's some questions about.
I'll let you pick, Michelle.
There's some questions about kind of overbearing parents that keep saying, are you taking your meds? How to sort of handle that. Sometimes a family might see psychotic symptoms, but the client denies it. How do you help them get to the similar? Anyway,
Okay,
we
so
might have to try to take some of these offline.
That's okay. Yes, and these are great questions. Thank you all so much for being curious about this. So for one of them, let's see, about the concern about, let's say, folks not knowing or agreeing on psychosis. When the content isn't lining up between two people, we can move to the experience. What is the impact or the functioning about this belief, or even the disagreement about the belief perhaps having on the family? So even though people may not be able to agree on whether or not something's real, chances are they can agree that they would like to fight less about it, or they would like to be able to feel less stressed about it, or sleep better at night, feel less anxious about it. And so talking with family members about how they can find common ground with their relative and use language that they can relate to, again, going back to what matters to the client, can really help so that you don't feel like you're putting a square peg into a round hole there. And the question about overbearing parents, I think every parent is concerned about being the overbearing parent. Like, no one wants that, and they're not trying to do that on purpose, I promise. And also, it might be a manifestation of the sense of urgency that families have. When they feel that sense of urgency, sometimes, whether they mean to or not, they end up having us feel that too. And so I think the "are you taking your meds" thing, we've had conversations with people who have lived experience about this very topic, and it's not great to be asked about that all the time. Like, I get that. And so sometimes thinking about what should families do, what should clients do, is a conversation best had together so that collaboratively a client and a family member or family members can talk about what the challenges are in that situation, what the options are in their eyes. Might they be able to try, realizing that it might come with some experimentation too. So for instance, could say, hey, I know taking your medication is really important. Your family thinks so too. They don't always see you taking it, and you don't want them looking over your shoulders. How would you like this to look moving forward? Having some open-ended questions about that can help fill in the blanks. You may not always come to be on the same page, but at least there's some conversation about it, so families aren't left in the dark and clients feel like you're trying to improve the family situation that they're in too.
Thank you so much. Please join me in giving a huge round of applause to Dr. McCarthy. This was really, really helpful. And I highly recommend, we're going to send out slides and a link to the recording probably within a week from today, hopefully. And I highly recommend checking out the resources. There were a lot of resources in those last few slides that can be a big help for answering some of those remaining questions that folks have as well. So thank you so much. I hope that this has helped people feel a little bit more prepared to work with families, to listen to families, to manage kind of challenging questions and that come up, and to recognize the importance of how much families can be helpful in working towards treatment goals. So thank you so much.
Thank you. And I just put my email in the chat if anyone has any questions, jmccarthy@mclean.harvard.edu.
Wonderful. Bye.
Bye.